Akshay, are you in? But I can't see anyone. Participants. So I don't know how it goes because I'm doing for the first time. Let's check with Kiri then. Okay. So you're in now? Okay. So do you want to start? Do you want to start? I'm ready. In fact, I'm ready. You have to share your slides and otherwise it's working, but now I'm in. But I'm not able to get anything else. Do I have to do anything from my side? Okay. ஓ அப்படியா ஏன்னா அட்டெண்டிஸ் 26 காமிக்குது ஒன்றுமே காமிக்கல எனக்கு அதுக்கு தான் சரி நான் இதை ஃபர்ஸ்ட் டைம் பண்ணுறேன் இது அதுக்காக தான் ஓகே ஓகே ஸ்டார்டிங்க்கு நான் ஒன்றும் பண்ண வேண்டியது இல்லையா ஸ்டார்ட் பண்ணுறதுக்கு நான் ஏதாவது பண்ணணுமா ஓகே I don't know. She may or may not. ஓகே ஓகே இல்லை நான் இன்வைட் அண்ட் கொடுக்கணுமா கீழே டு யூ ஹேவ் டு டூ இன்வைட் டு எவ்ரி ஒன் நான் பண்ண வேண்டியது இல்லையா ஓகே சரி ஓகே
Some presentation, sir?
Yeah, you can start. Akshay? Akshay, are you in? Hello? Down, you can see a green button, share. Just to scroll your mouse down, then you'll see a green with a share button.
Is the participant name Akshay Babu?
Yeah.
He's in the attendees list, so I will just promote him to panelist.
Okay. Akshay, just you have to wait, I think. You'll have to get back in. So because there you'll get a share option, then you have to show the sharing. Is it done?
Srinivas sir, Girita here. I have logged in, sir. Probably once the participant number reaches around 50, we can start, sir. Another 5 minutes more.
Yeah. Actually, Akshay, the presenter, was in the normal attendees list.
Oh, no, sir. I think you can send the. Have you forwarded the link to the presenter, sir?
I think one of them did send, I think, because someone spoke to me as faculty. He told he'll send it.
Okay.
I was trying to promote him from the pan attendees. He's not available. He's not there at the moment.
Okay. Sir,
I'll tell him to join using this link. Please give me a minute, no?
yes, Abhi. Yeah.
Want to share the host, right, sir?
Uh, Debarun, can you share the host rights to Dr. Abhiram Lata?
Uh, I can, sir. Who in the
Yeah,
panel? Where is she?
no, 1 minute. Abhi, can you name yourself instead of when in a faculty? Can you name yourself?
Yes, sir. Yes, sir.
Debarun, you can make Dr. Srinivas the host now and make me the co-host also. Yeah, I'm already the co-host. You can make Dr. Srinivas the host.
Okay, Akshay, I think promoted to panelist now. I think he can share.
Yeah.
Dr. Srinivas is the host now.
Yeah. Thanks, Debarun. Yeah. Welcome, delegates. I think we'll start another session of the NOEL. And I would like to welcome Dr. Srinivas Ramakrishnan. Dr. Srinivas is the clinical lead in neonatology at KMCH Hospital in Coimbatore, Tamil Nadu. Welcome, sir. And
Thank you.
Dr. Akshay, the NNF resident there, will be presenting a preterm child on a ventilator. And this session will be also hosted by Dr. Abhiram Lata, who's another consultant at OA Medical Center Hospital in Coimbatore. Welcome, Dr. Abhiram Lata. Over to you guys.
Akshay, are you in?
Hello, can you hear me, sir?
Yeah.
I'll start, is it?
Yeah, you can start.
Good evening, everyone. Today's topic is extreme preterm baby on ventilator support. Myself, Dr. Akshay, fellowship trainee from Koya Medical Center and Hospital Coimbatore. My moderator is Dr. Srinivas, senior consultant, head of the department, neonatal unit, Koya Medical Center, Coimbatore, and another moderator, Dr. Abraham Ledal. We change our moderator. Okay. Okay, this baby of K, male baby, postnatal age 34 days, postmenstrual age at birth, 23 plus 6 weeks. Corrected gestational age 28 plus 5. Birth weight is 540 grams and current weight is 600 grams. Antenatal history: mother is a 27-year-old. When father is 31-year-old. Non-consanguineous marriage. Married for 5 years. Primary. Mode of conception is assisted. Induction of ovulation conception. Folic acid started 4 months before conception. First trimester, pregnancy confirmed by UPT, urine pregnancy test at 7 weeks of amenorrhea. Dating scan was done at 7 weeks of gestational age, was found to be normal. NT scan was normal. No history of fever with rash, radiation exposure, or medication other than folic acid intake. Second trimester, quickening felt from 16 weeks of gestation. Iron and calcium tablet supplements were started. 2 doses of TT was given. Blood sugar and BP were within normal range. Anomaly scan done at 20 weeks. No fetal anatomy, normal fetal anatomy, and normal Doppler seen. At 23 plus 1 week of gestation, mother had spotting per vagina. Baby mother was taken to hospital. Cervical and incompetence was suspected, and cervical encirclage was done. At 23 plus 5 weeks, mother was brought to KMCH with PPRIM for 18 hours. There was no history of fever, foul-smelling vaginal discharge. Mother was started on IV antibiotics. Counts and CRP was sent and was found to be normal range. NST was found to be reactive. 2 doses of betamethasone was given. The second dose was given 6 hours before the delivery. Magnesium sulfate was given. Birth history: mother had preterm labor and baby was delivered at 23 plus 6 weeks by vaginal delivery. Baby did not cry at birth and was floppy. No spontaneous effort, and heart rate was less than 100 beats per minute. 2 cycles of positive pressure ventilation were given with starting FiO2 of 30%, which was gradually increased up to 100%. Heart rate was still less than 100. So baby was intubated and continued on invasive positive pressure ventilation, after which heart rate improved and FiO2 requirement decreased up to 35% gradually. Baby was thereafter shifted to NICU with TPS resuscitator. Now coming to the list of problems which we are going to discuss. RDS and evolving
Now,
CLD.
Akshay, can we have some discussion on the antenatal history?
Yes, sir, yes.
Okay, so she was a primary, is it not?
Sir, primary mother.
She was a primary, okay.
Yes,
And there was a suspicion of cervical incompetence. Was it a proved one or just suspected cervical
Sir,
incompetence?
according to mother's history, cervical incompetence was suspected. It was not like confirmed.
Now, what are the
On per
evidence
vaginal
for-
examination, cervix was like little dilated. So
Now, at this stage, what do you think is the reason for a premature onset of labor?
actually, this cervical encirclage causing infection, induced infection, can itself lead to premature labor. That's a risk factor.
No, but did she have any history of fever?
No history of fever.
Nothing was there.
Nothing was this.
So here, the only risk factor you have noticed is a cervical encirclage due to
Yes.
suspected cervical incompetence, isn't it? Okay.
Yes.
But any family history of prematurity?
No.
No.
According to history, no family history of prematurity.
Okay, go ahead.
Thank you.
And the other thing I wanted to ask was, do you always resuscitate a baby extreme premature baby less than 24 weeks of gestation?
Yeah, normally we will resist.
Okay.
Sir, question once more, sir.
No, do you always resuscitate a preterm baby delivered less than 24 weeks?
Not always, sir. We will try to make it more than 24 weeks. After the period of viability, once period of viability is closed, only we will normally. But in this kind of scenarios, we will do so.
Okay, I think this was a parental request where we had to continue with the resuscitation, isn't it?
Since 5 years, they were not having kids.
Yeah, okay.
Thank you. So, list of problems so far is RDS and evolving CLD, hypotension, HSPD, hyponatremia, neonatal hypobilirubinemia, hypertension, hypoglycemia, hypertriglyceridemia, hypokalemia, hypophosphatemia, and feed intolerance. So first coming to respiratory distress syndrome and involving chronic lung disease. Baby was given 1 dose of curosive. Pre-surfactant FAO2 requirement was 50% and post-surfactant was 25%. In
So
view of
here, just a
Sir?
minute, you said 1 dose of curacao. When was it given? Was it given in the delivery room or in the NICU?
Actually, it was given in the NICU only, sir.
Why?
Normally,
Because
we'll
baby was intubated in the delivery room.
intubated, sir, but it was emergency, sir. Like it was baby came out very fast, so actually
Very fast.
surfactant was
Okay.
not.
They were not prepared.
Taken.
Okay.
Yes, yes, sir.
Okay.
So baby was given 1 dose of curosive, pre-surfactant
Can you
50%
tell
and
me something
post-surfactant was
about
25%.
prophylactic surfactant, then early rescue and late rescue? Because we may miss if we discuss in the end. So, yeah.
Prophylactic surfactant is normally not recommended. That is
Not
like
recommended.
immediately after delivery, a dose of surfactant is given, sir.
Okay. So generally we don't give a prophylactic surfactant.
Early,
Mm.
yes,
Okay.
not recommended. Early rescue surfactant is within 1 hour of life. If FAO requirement is more
1 hour
more
or
than
2
30 watt,
hours?
which we follow. Sir,
1 or 2
1
hours?
to 2 hours, 2 hours of life.
Okay. What is the indication?
If FAO2 requirement is more than 30%, it is indicated, sir.
Okay.
And
Good.
late rescue is after 6 hours, sir. After
2
2 to
hours.
6, 2 to 6 hours.
Okay. Okay. Good.
Okay. So in view of pure spontaneous efforts, baby was started on invasive ventilation, PRVC mode, tidal volume of 5 ml per kg, peak was at 25, PEEP of 6, I time of 0.35, backup rate was kept at 50, and FAO requirement was 25%. A UVC was secured, and the left radial arterial line was inserted as UAC couldn't be secured, sir. And X-ray was taken to confirm the UVC position. After this X-ray, UVC was withdrawn, 1.5 centimeter was withdrawn and was kept at the level of diaphragm. Since arterial line was
In case you are put in UAC, what would be the ideal position for UAC, umbilical arterial line?
T6 to T9.
T6 to T9. Okay. Why not below T9?
So
Because lot of things
because
are there.
branches will be
It's learning curve.
branch. Hello, sir.
Tell me.
Branches will be present, sir. So
What branches?
portal vein, liver injury.
So it's the mesenteric and the celiac vessels which supply the gut. Okay. So if the tip is below that, it can interrupt with the blood flow to these blood vessels and it can cause problems in the intestines. Okay.
Blood supply to the intestine.
Okay.
So VBG was done at 2 hours of life. pH was VBG. pH was 7.34. PO2 was 35.9. PCO2 was 41.6, and HCO3 22.2. Lactate was at a higher range of 50.3. On examination, baby had a poor perfusion. So bolus was given at this stage at 10 ml per kg. NS. On day 2, there was a sudden desaturation and air entry not heard on auscultation even after suctioning. So dope was considered, tube displacement was suspected, position of tube checked by laryngoscope with ET in situ. So tube obstruction was doubted. So baby was extubated, showed a thick mucus plug completely obstructing the distal ET. Since baby was maintaining vitals well with good spontaneous efforts on TP's resuscitator, baby was connected to a bubble CPAP with PEEP of 6 and FAO2 of 25%.
So what are the components of Akshay?
Sir?
What are the components of dope?
Sir, displacement, obstruction, pneumothorax, and equipment failure.
Equipment failure. Okay. So displacement, how do you detect? Clinical examination, what are the findings in displacement?
Air entry, like so on auscultation, air entry will be affected. So like bilateral air entry will not be heard. And ETCO2 also we can try.
Movement of the ET tube also could be noted above. Okay.
Yes, sir.
So on checking, the tube may be more high or too below, or it
Maybe
could be
below.
up to the thing. So what about obstruction?
Obstruction, most commonly pressures will not be delivered, sir. It will be
Pressure
obstruction
requirement may go up,
will be go up.
then air entry may be asymmetrical, decreased, or totally absent. Okay.
Yes.
And what about pneumothorax?
Pneumothorax also, say like air entry will be affected. On auscultation. Air entry cannot be heard, sir.
There may be a sudden clinical deterioration, is it not? With an
Sudden
increased
clinical
oxygen
deterioration.
requirement. Okay, and then how do you detect this?
Transillumination methods are most easier.
Transillumination. So whenever you have a suspicion, always transilluminate and see.
Okay.
With equipment failure, what are the things you would like to have a look?
Like is there any leak and tube leak or anything in the
Circuit leak. Circuit leak could be
circuit.
there. Oxygen supply may not be there. All the central supply may not be there. Sometimes equipment itself may totally fail. Okay.
Yes.
Okay. Go ahead.
Thank you, sir. So on day 3 of life, there was a persistent FiO2 requirement of more than of 30% when baby was on CPAP. So actually, a chest X-ray was done, sir, which showed a right lung collapse. So CPAP peak was increased to 8. 3% NaCl nebulization was started in view of thick secretion, and left lateral positioning, that is right up positioning, was done. On day 9, UVC was removed and PICC lane was secured. In this X-ray, we can see well expanded lungs, bilateral well expanded lungs, and PICC lane in position. On day 11 of life, frequent apnea and desaturation was present. Respiratory support was escalated to NIPPV with the support of PIP 18, I time of 0.45, PIP 7, and respiratory rate 50. On till day 17, that is for 5 days, baby was maintaining well with NIPPV. So on day 17, FiO2 requirement increased till 65. Baby was intubated and started on invasive ventilation. So the first X-ray is before intubation, showed bilateral collapse lung, and baby was started on PRVC mode with the tidal volume of 6.5 ml per kg, I time of 0.35, PEEP 7, backup rate of 45, FiO2 35, and required PIP of 22 to 25. And an X-ray was taken after 6 hours, and ABG was taken after 1 hour of intubation. Showed a pH of 7.131, PO2 of 63.3, PCO2 of 53.6, and HCO3 of 20.4. For this ABG, rate was increased to 50 from 45. On day 19, FiO2 requirement again baby was not maintaining well with PRVC mode. FiO2 requirement increased to more than 60. So baby was changed to HFOV with the setting of MAP 17, amplitude 27, frequency 10, and IE ratio 1.1:2.
So now with the settings here, HFOV, how do you decide on the pressures, amplitude, and also frequency?
Based on in PRVC mode, what was the map which was baby was getting was around 15, sir. So we increased 2 and kept map as 17, sir.
Okay.
Amplitude was decided on the wobbling of abdomen, sir.
Wiggling of the
abdominal wobbling, sir, like
just abdomen and upper part of the thigh.
upper part of the thigh.
Okay,
Frequency normally at 10, sir. And inspiratory expiratory ratio 1:2.
So frequency, how do you decide on the amount of frequency?
So normally we in our unit will keep as 10, sir. Normally
Generally
8
for a
to 12.
preterm baby, we start at 10 to 12, and a term baby 8 to 10. Okay, that's the frequency.
10, 8 to 10. ABG, okay, so continue, sir.
Yeah, continue.
So ABG was done after 1 hour of HFOV, which showed a pH of 7.4, PO2 of 47.5, PCO2 of 30.2, and HCO3 of 18.6. So in view of carbon dioxide washout, like PCO2 of 30.2, amplitude was reduced from 27 to 22. At this time of ABG, DCO2 delivered was 36.
So after looking at this calibration, just go back. PCO2
Yes,
was 30 and DCO2 was 36.
yes, sir.
So what DCO2 would you prefer in this baby to have a normal CO2?
No, normally DCO2 value preferred is weight square into 40, sir. But for this
Yeah.
baby, like what we follow is like depending upon the consecutive gases, we will prefer what DCO2 to keep.
Yeah.
Because
This
sometimes,
formula generally it's very difficult in extreme premature babies. It doesn't. So always you should have a correlation. In
yes,
this gas, you have got a correlation when DCO2 was 36, CO2 is 30.
30.
So if you want the CO2 to go up marginally to the normal values,
Mm.
you have to decrease your DCO2, isn't it?
For which amplitude was reduced.
So what was the DCO2 target later, subsequently?
Subsequently, actually after a few hours, we repeated one gas, sir. Again, further fall in the DCO2 was noticed.
So
To
that's a wrong thing, isn't it? DCO2 is a continuous monitoring. Here you allowed the DCO to go up.
Yes, sir.
So that should not have
Here,
happened here, isn't it?
here
DCO2
the
should
DCO2
come.
went up, sir, to 46. So in with this gas, we reduced amplitude to 18, and DCO2 was correlated, and the target DCO2 was kept at 10 to 30.
So here you can see a PCO2 of 23. Do you think
Yes.
it's good for the baby?
No, sir. It can cause brain vasoconstrictions.
What is the biggest risk
Cerebral.
factor with such low CO2?
Cerebral vasoconstriction. So ischemia can happen. So can affect baby's brain, and bleed can happen.
Yeah, IVH is the biggest risk factor when you have a significantly low CO2. And did you check with an ultrasound after this next day?
Yes, sir. It was, yeah, bedside screening was done, sir. There was no IVH, sir.
Okay. So, but we should never ever allow the CO2 to go such in low condition. Ideally, it should be between 35 to 45, not less than 35.
Yes, sir. Yes, sir.
So anything less than 35 can increase the incidence of IVH, which is a very bad outcome for these babies. So this, okay. Luckily, there is no IVH in this. Okay.
Yeah. So after 12 hours of this, ABG was repeated, which showed a pH of 7.3, PO2 of 52.9, and PCO2 of 35. HCO3 18.2, DCO2 at this time was 25. So amplitude was further reduced to 16, sir, and mapped to 14 because FiO2 requirement was 25%. After 6 hours, again one more ABG was repeated, which showed a pH of 7.29, PO2 of 57.4, with an FiO2 requirement of 23, PCO2 of 51.2, and HCO3 of 20.4, with the DCO2 at that time was 15. So MAP was reduced further to 12, and amplitude was continued at 60.
Okay.
On day 24, HFO settings were beamed to a map of 11, amplitude of 12, and frequency of 10, i.e. 1:2. At this time, DCO2 was 15. At this time, one ABG was repeated with the setting, which showed a pH of 7.32, PO2 of 58.2, PCO2 of 46.5, and HCO3 of 23.4. So on day 24, baby
I think
was
from all the gases which are shown,
sir,
go back. From all the gases which are shown, the DCO2 would have been ideal if it was targeted around 20 to 25, isn't it? So the pH would have, CO2 would have been ideal. Okay.
yes. So baby was changed to conventional ventilation with PRVC mode with a tidal volume of 6 ml per kg with Pmax 25, PIP of 6.5, and I time of 0.34 seconds, the respiratory rate of 45. ABG was done after 1 hour of starting PRVC mode, showed a pH of 7.32, PO2 of 53.8, PCO2 of 53.7, and HCO3 of 25 millimoles per liter. X-ray was taken after this, which showed a right upper lobe collapse. So actually, tube position was checked. It was found to be in right position. So a traction was kept for the tube.
So what is the other thing which could have caused this picture? Is it only the tube displacement or anything else can cause?
This baby, there was a history of mucus, thick
Thick secretion.
mucus,
So
mucus
sometimes
plug.
even the secretion blocking the upper lobe.
Upper lobe can be.
So upper bronchi can cause this problem. Okay.
On day 29, baby was planned for extubation, and mini ball culture was taken before extubation, sir, because there was a prolonged intubation. So baby was extubated to NIPPV with a PIP of 18, PEEP of 7, and I time of 0.45, respiratory rate of 45 per minute. Ball culture came initially antibiotics was not started. Ball culture showed a carbapenem resistant Acinetobacter baumannii. So initially considered as colonization, and antibiotic was not started, sir. But on day 22, ABG and X-ray was repeated, sir. So ABG was 7.338, PO2 of 57.8, PCO2 of 47.6, HCO3 of 25, with chest X-ray showing suspected VAP. So baby was started on colistin and tigecycline duty report.
In view of ball culture, isn't it? Okay. But blood culture was negative.
Ball culture. Blood culture was negative, sir. But baby was constantly requiring an IFU 25. So to prevent further infection, we started on colistin and tigecycline.
Okay.
Currently, we is on say of 6 of 7, time of 5 respirated of 40. Only on
Your voice is breaking, Akshay.
Hello.
Yeah. Okay.
Can you hear me, sir?
Yeah. Okay.
Hello. So currently, baby is on NIPPV with a PIP of 16, PEEP of 7, I time of 0.45, respiratory rate of 40, and antibiotic tigecycline cholesterol.
Okay. So initially, you have started you have treated the RDS, isn't it? Respiratory syndrome of extreme premature baby weighing, gestation being 23 plus 6 weeks, very low birth weight or extreme low birth weight weighing only around 540 grams. So what would be the golden hour management in the delivery room when you're called in there?
So we normally prefer immediately after baby will be resuscitated under the radiant bomber. Initially, we will inform we will receive the baby in neorabs. Temperature management is the first thing which we will follow.
Then
you
don't want a delayed cord clamping?
Hypothermia. Delayed cord clamping will be informed to the physician, sir. If baby cries immediately, now we will ask for delayed cord clamping from 1 to 3 minutes.
Most of the time, these babies will not cry.
Most of the time.
Stable enough, then you can always go for a delayed cord clamping, which is beneficial for the baby. Okay.
Okay.
And then temperature, then early CPAP. Early CPAP is very, very important.
Early CPAP.
Why do you think early CPAP is very important in these babies?
Early CPAP, sir.
Why is it very important here?
To prevent the lung from collapsing.
Okay, so
after
in
delivery,
utero, the lungs are always, all the alveoli are open. Alveoli or sacals are open because of the liquor. So it
Liquor.
keeps open. So as soon it comes out, once the liquor is being washed out, it may collapse very quickly.
Very
So
quickly.
by giving early CPAP, though the liquor is washed out, you are replacing it with air with your CPAP, pressured air.
Oh,
Early CPAP will prevent the collapse of the airways. That's an added advantage in this baby by giving early CPAP without any delay. The resuscitation should start with early CPAP. Okay.
then warm room temperature should be maintained, sir.
Okay. Yeah.
Preheated radiant warmer should be made. Warm towels, caps.
And preferably we should use humidified air and
O2.
oxygen for these babies.
Humidified oxygen, sir.
Okay, then.
Here in our unit, we used a TPS resuscitator for resuscitation, sir, which provides a proper PIP, calculated PIP and PEEP, sir.
Okay. Plus, I think we had a humidifier also for this, isn't it?
Yes, sir. Yes. In
Okay.
we are having humidifier.
Okay. And because the baby was delivered early, you were not able to give surfactant, though the baby was intubated.
Yes, sir.
So, okay. And then in the delivery room, you are given the early rescue treat surfactant.
Yes.
And subsequently managed with CPAP, isn't it?
Yes, sir.
Okay.
Followed by CPAP was started. CPAP was continued.
And subsequently, the baby required assisted ventilation. So,
Yes, sir.
what is the most
As per
ideal
PRVC.
ventilator method you would like to use?
We like volume guaranteed method, sir. PRVC is the
Volume
most
guarantee ventilation. Okay. Why do you want volume guarantee ventilation?
in volume guarantee, a particular volume will be delivered to the baby with fluctuating pressures. Pressures also, maximum pressures, we can control the pressures. So within this
here
set
every volume
pressures,
is calculated and machine delivers the required support with every breath, isn't it?
yes, yes.
And adjust the pressure. So the advantage of volume guarantee ventilation is
Ideals.
decreases the volume
Reduces the volume trauma.
which is a major component which can damage the lungs significantly. So that's
And
why now the preferred mode. Yeah.
And regarding complaints, sir, like in volume guarantee, once baby's lung starts improving, pressures delivered can be like it will be automatically reduced.
automatically decrease. So you don't have to depend on others. Okay. So there is an auto weaning which happens, which minimizes the lung damage again.
Yes.
Otherwise, we have to depend on one person who keeps looking at the volume and then adjusting. So the weaning will happen by the machine itself, which prevents lung damage. So that's the best advantage of VG. Okay.
Yes.
Okay. Next. Okay, you can go to the next component.
So next is suspected sepsis. So antibiotic was started on day 1 of life due to risk of sepsis in view of PPRM for more than 18 hours and preterm labor. Since sepsis screen was negative and blood culture was sterile, antibiotics were stopped after 72 hours. On day 17 of life, there was history of recurrent apnea for which sepsis screen was done and which was negative, so antibiotics was not started. On day 3 of life, now coming to HSPDA, on day 3 of life, in view of wide pulse pressure, 2D echo was done, which showed a large 2.5 mm HSPDA with left to right shunt with an LA over ratio of 1.5. So baby was started on injection paracetamol at 10 mg per kg per dose, Q6 hourly for 5 days. Review echo was done on day 5, showed closed PDA. Coming to hypotension, on day 4 of life, baby had hypotension with a map of 23. Tachycardia was present. CRT was prolonged 5 seconds and low volume pulse. So at 10 ml, suspecting reduced volume, 10 ml per kg NS bolus was given, which showed a marginal improvement. So one more 10 ml per kg NS bolus was given, which also showed a marginal improvement, but was not persisting. So baby was started on dopamine infusion. Dopamine was started at 6 mg per kg per minute and was increased to a maximum of 12 mg per kg per minute. Dopamine was weaned once hemodynamic baby was stabilized and stopped after 72 hours.
So here, because one of the discussion is based on the inotropes, so why did you
Yes, sir.
select dopamine here?
Sir, in our unit mostly preferred is dopamine, sir,
Not
and in
entire.
case of hypovolemic shock, suspected hypovolemic shock, dopamine is the most ideal. It causes both peripheral vasoconstriction and increases cardiac
Contraction. So, okay, dopamine is the one which is maximum studied in neonates. So most of the units
Yes.
try with dopamine, but other drugs also can be used which are good enough. So here dopamine was used mainly
Normally-
for increasing the systemic vascular resistance so that BP can come up. BP was low, is it not? In spite
Yes.
of boluses, BP was not coming up, so you started increasing the systemic vascular resistance. So initially, why did you give bolus?
Because in case of hypovolemic shock,
There was a tachycardia and a prolonged CRT, 5
prolonged
seconds, which tells that it could be low volume.
low volume.
What are the other inotropes which you could use here?
Sir, first, like normally we'll check cardiac contractility, sir, like with an echo machine bedside. So if cardiac contractility is so bad, like not good enough, now we'll normally start with dobutamine, sir. Dobutamine. And if in case of suspected PPHN or with the good BP, maintaining good BP,
Will dobutamine increase the BP?
No, sir. Dobutamine will not increase.
It can. In higher doses, it can. But in smaller doses, mainly it's a inotropic, increase the contractility.
Okay. Sir.
Okay. And also there is improved heart rate. Tachycardia, this increases the heart rate and contractility. But at higher dose, it will have some alpha effect. Dopamine has got mainly on the alpha effect, that is increasing the system vascular resistance. So in bigger children and adults, they say dopamine at a lower dose increases the renal vasodilation. So improves the urine output. Does it happen in neonates?
No, sir.
So it's not established. We can't say, but always we can try. It's not established whether it is helpful in improving the renal blood flow at lower doses. So maximum effect of dopamine is at around more than 10 mics to improve BP. So always you start with 10 and increase or decreasing according to the BP. Okay. So other inotropes which could be used?
So adrenaline less than 0.3 now, it mainly causes increases contraction and peripheral vasoconstriction. More than 0.3, 0.4 to 1 mostly causes only vasoconstriction, sir.
Okay.
In case of refractory
adrenaline has got a special action, especially when there is a PPHN. Do you know? Some of the studies have shown that adrenaline may be a preferred drug when there is a PPHN.
Pulmonary vasodilatation, sir.
How?
How?
So actions on alpha receptors and beta receptors, isn't it? So it has got some action on the beta 2 receptors, which is selectively high in lungs.
Okay.
So these receptors are selectively high in lungs in a newborn. So that's one of the reasons there can be a vasodilation in the lung. And some of the studies have shown that it can help the babies who have got severe PPHN. So adrenaline is one of the preferred drug in PPHN. Okay. Then when do you use noradrenaline?
Is mainly for peripheral vasoconstriction, sir. Without any effect on
There is a
heart.
severe shock. Okay.
In case of warm shock.
Noradrenaline is the most significantly, it increases the SVR system. It's almost like 4+. Increases vascular constriction. Okay. Resistance. Okay. Noradrenaline is the preferred severe shocks. Okay. Especially warm shock. Okay. Suppose there is no response to all these inotropes, what would be your approach?
Vasopressin.
Vasopressin can be tried, is it not?
Yes, sir. Vasopressin.
Yeah, vasopressin, what is the added advantage of vasopressin?
Sparing renal flow will be spared.
So renal flow will be saved. spared, okay, then it also can act
Then
efficiently in severe
pulmonary
acidosis. Whereas all the other inotropes may not function efficiently when there is severe acidosis. Vasopressin can act even with severe acidosis. So that's an added advantage with vasopressin.
Yes.
Okay. Anything else which you would try routinely, which is used in most of the units when the response is not adequate and there is hypoglycemia also noted?
Hydrocort can be tried.
Hydrocortisone, steroids can be tried because sometimes steroids increases the sensitivity of the
sensitivity of
receptors. It increases the sensitivity of receptors and improves the functions of these catecholamines. Okay.
Yes, sir.
So these things you should remember. Dobutamine, dopamine, adrenaline, noradrenaline, vasopressin, and also hydrocortisone. Not to forget
Right.
hydrocortisone.
Yes.
Okay. Okay. Next.
Next, coming to hypernatremia. Baby was found to have hypernatremia from day 2 of life. Sir, highest value was found to be 85 millimoles per liter. Baby was managed by increasing the TFR fluid required up to 2 ml per kg per day, and with each wear, sodium level was slowly decreased over 4 days.
Okay.
So
Why do you think there is such a high sodium?
So during this time, baby had significant weight loss.
Weight loss. Why do you think there is a weight loss?
Because of like baby was kept initially under radiant warmth. So skin loss, unsensible water loss will be worse.
So there is a significant transepidermal water loss.
Transdermal loss.
Yeah, so that's why. So these babies' skin is very immature and there will be a significant water loss through the skin.
Transdermal.
Okay.
Now coming to hyperglycemia, baby had a high sugar level from day 3 of life. As TFR was increased for hypernatremia, glucose concentration was reduced and insulin infusion was started. Sugar was stabilized after 36 hours.
What is the
Hyperbilirubinemia.
indication for insulin here?
Hello.
Indication for insulin.
Hello. So, baby had a high, RBS level persistently more than 180, sir.
Okay. And you are not in a position to decrease the volume because sodium also was very high.
Volume was also not. Yes.
So you have to balance and you have to make the receptors utilize the glucose. That's why insulin was started. Okay. Okay, next.
Hyperbilirubinemia. Mother's blood group O positive, baby blood group O positive, DCT negative. Weight loss was around 12% on day 2. And serum bilirubin was around 7.6. Baby was started on phototherapy, which falls in phototherapy range. So baby was started on phototherapy, was continued for 48 hours and stopped.
Okay.
Hypertension on day 19 of life, baby's BP was noted to be on higher range, more than like 90 to 90 percentile.
Slide is not changed.
BP of 70, 48, 55. Sir?
Yeah. No, slide was not changed. That's why I told. Okay. So this baby had a sudden increase in BP. Okay.
The fresh blood BP with mean BP of 55, which falls at 95th percentile. During this time, serum creatinine was found to be elevated at 1.8 milligram per deciliter. So a renal Doppler and echogenicity was done, which was found to be normal. NSG was done, which showed no bleed. So baby required a sodium nitroprusside infusion for 36 hours, after which BP
What do you think is the cause for BP to go up here? What are the reason for sudden BP? Actually, it was more than 55. It was going even up to 65, 70 also mean.
We were suspecting AKI.
Probably serum creatinine tells that there could have been renal injury and late changes of probably increased hormones in the renal, that is angiotensin, which could be increasing the BP. Okay. So renal Dopplers may not always detect these problems, so we'll have to think of other things also. And why was sodium nitroprusside started in this case?
Because in case of AKI, because we suspected AKI for renal protection, we suspected sodium nitroprusside. Beta blockers.
Persistently high BP. So
Mm,
which is a risk factor for IVH.
Mm.
So that was the reason, because we couldn't keep these BP so high for a long period. So that's one of the reasons why we started sodium nitroprusside. Okay. Next.
The next slide is hypertriglyceridemia and anemia. On day 11 of life, baby was found to have yellow deposits over the skin or legs and around the armpits. So there was a hemoglobin discrepancy between the Coulter value, which showed a value of 14.2, and the ABG value, which showed a value of 6.8 HB. So for PCV was found to be 22%, which was low, and RBC also found to be 1.58 million per unit. So base TGL level was found to be 4,982 milligram per deciliter at 3 gram per kg lipid in DPN. So what we did was a lipid infusion was stopped, and um, a blood transfusion was planned, so like given 20 ml per kg, thinking like ABG value of 6.8 is correct. So repeat TGL was
Why
done
do you think ABG
after
value was
48
correct?
hours. So
Why do you
because
think high lipid levels can?
because worked up further, PCV was found to be 22, sir. So if we measure based on this thing PCV, it will come around 7, sir, 7.2, and
High,
RBC was also low.
yeah,
And
high
when we
TGL
further
levels can
worked
give
up,
us spurious values of hemoglobin in the routine
so
Coulter.
high TGL level of
Mm.
this thing 4,982 was there, so
Yeah.
it can give a higher range of P. This is because spectral interference light scattering will happen, sir, during Coulter method.
Okay. Okay, go ahead.
So repeat TGL was 48 milligram per deciliter. So lipid infusion was started back at 1 gram per kg after 48 hours.
Okay.
Hypokalemia and hypophosphatemia. Baby had a low potassium of 2.9 milliequivalents per liter and phosphorus of 1.9 milligram per deciliter. Managed with the TPN. TPN electrolyte composition was adjusted, after which levels were normalized. Coming to feed intolerance and nutrition, baby was started on tropic feed and total parental nutrition from day 1 of life. Feeds were gradually increased. On day 23 of life, baby had abdominal fullness and bilious OG aspirate. So feed was cut down and TPN was further increased. Gradually, feeds were reinitiated and increased. Baby tolerated feeds well, sir. Now currently, baby is on full OG feeds and tolerating well. On examination, baby is under radiant warmer with NIPPV support and continuous pulse oximeter monitoring. Baby is pink, euthymic, criterion activity good, CRT less than 3 seconds. Heart rate of 148 beats per minute, SpO2 98% with NIPPV support, respiratory rate of 50, BP 60, 36, 48, temperature 97.8. Anthropometric uh,
What is
findings
the
both
oxygen requirement here?
currently baby is requiring 21 to 25
Okay.
for a target SpO2 of 90 to 95. We always follow 90 to 95.
So finished?
No, sir. Anthropometry. So at birth, weight for age was between 10th and 50th centile. Height for age was between 3rd and 10th centile. Head circumference for age was between 10th and 50th centile. Currently, weight, height, and head circumference for age is less than a third centile.
So we were not able to reach the required calories for this baby.
Yes, sir. Because of recurrent like ventilation, you are not able to maintain
Okay.
adequate. Currently, nutrition, baby is on full feeds with EBM and OG with a TFR of 180 ml per kg per day with HMO fortification and MCT oil. Total calories getting delivered is 126 kilocalorie per kg per day, and protein is 2.8 grams per kg per day. Thank you.
Now summary.
The an extreme preterm baby at 23 plus 6 weeks, a birth gestation of 23 plus 6 weeks, and birth weight of 560 grams. Baby mother had a history of PPROM for 18 hours, following which baby was delivered. Extreme preterm, extremely low birth weight, delivered via vaginal delivery due to PPROM. And preterm labor required intubation at birth during resuscitation, and baby was connected to mechanical ventilator initially. On day 2 of life, baby was in view of spontaneous efforts. Baby was continued on CPAP, sir. Then baby was again requiring a higher respiratory support. Initially went to NIPPV, followed by mechanical ventilator, PRVC mode, then followed by HFOV, sir, which was slowly weaned off, and baby was extubated to was changed to conventional ventilation, followed by extubation to NIPPV. Currently, baby is on NIPPV support, maintaining well, sir. During extubation, one ball culture was taken, which showed crab infection, for which currently baby is on antibiotics.
Okay. Baby also had a significant hypernatremia, had an episode of hypotension, hypertension, which are all managed, and baby required about 2 or 3 blood transfusion, isn't it?
2 blood transfusion.
You mentioned about the blood transfusion only once you mentioned.
Once.
So baby deteriorated twice after blood transfusion.
Yes, sir.
Okay. Okay. Now, Dr. Giridhar, how much time we have? Because 1 hour over. Here, Abhi? Okay, faculties are not here. So now here to summary to all the participants, just to give you so here a baby was born at 23 plus 6 weeker. Generally, we don't offer treatment to any baby less than 24 weeks. But sometimes on special request from the parents where it's very precious baby for them, we try to support as long as the baby comes in a reasonably good condition. After taking all their risk factors, we'll explain the parents, take their consent, and then only we start resuscitating these babies. And if the babies do well, we continue with resuscitation. So this baby improved nicely after the dose of surfactant, and pressure started coming down quickly. Oxygen requirement came down. So we decided to continue. Only thing, major problem we faced was significant hypernatremia in these babies, which is anticipated because of we didn't have an incubator at that time because it was occupied by other babies. So initially we had to manage in the open care, which could have contributed to the hypernatremia. And this baby luckily didn't develop any blood culture positive infection, though there were few episodes of sepsis. And also baby had hypotension at one stage, cause not known, but we had to support with more fluid and inotropes, stabilized. Then possibly there was an insult to the kidney, which led to the raised creatinine and also hypertension, which was again brought down by sodium nitroprusside. And this baby is, though we had lots of ups and downs, is doing reasonably well, has reached full feeds. still on NIPP support, but oxygen requirement is minimal. Baby is doing well at this time. So here with learning curve, always neonatology is prevention. We should never allow a problem to happen, because once the problem is happening, then the outcome will be much worse comparatively. So main aim of treating these extreme premature baby is prevention of the problem. So now if you have any questions for all the participants, you can ask us. We'll try to clarify. Because of shortage of time, I'm not going into the details of inotropes and ventilation. I think we have reasonably discussed about it, how we should approach in a small babies. But if you have got any questions regarding inotropes or ventilation, you can always ask. I'm seeing one question. Can we give milrinone in thrombocytopenia cases? A good question. I'm not sure about this, because I have to find out, because we not faced this problem. But generally, milrinone is a safe drug in newborns. Especially one thing you have to be careful. Whenever you want to start milrinone, you have to make sure the BP is normal. Otherwise, in case of PPHN, whenever you want to start with milrinone, keep an inotrope also as a backup support, because with milrinone, the BP can come down significantly. So you have to be very careful whenever you start milrinone, because of the peripheral vascular dilation, there can be a drop in BP. So that's one thing which I should remember when you're commencing milrinone. Thrombocytopenia, I'm not sure, because we have not faced that problem in our NICU. We have to look on that. So nitroprusside versus enalapril. Okay. So here again, most studies, and even in Australia when I was there, most of the cases when there is a high BP, it will be either GTN or nitroprusside. But these are the drugs which are commonly used in premature babies or neonates. So enalapril, probably a bigger babies you can go for it, but not in extreme premature babies. We are not very comfortable with that. Third question, what was your feed increment guideline? So in our unit, the guidelines is generally we start trophic feeds right on day one. We in extreme premature babies, we don't even start at 15 ml per kilo. We start at around 0.5 ml fourth hourly or second hourly, based on how the baby is stable. And each day we try to increase by 0.5 to 1 ml, which is almost equal to 10 to 15 ml per kilo. But we look at every aspect of the baby, whether the baby is developing any feed intolerance, abdominal distension, whether the baby is passing motion regularly. Based on all this, we decide on the increase in feeds daily. So that goes case by case after examining the baby daily and looking at all the other factors. So if there is significant aspirate, more than 50%, we don't increase. If there is less aspirate, we try to increase. If the baby is passing motion regularly, we try to go a bit fast. If there is no abdominal distension, we try to go a bit fast. Generally, most of these babies, we may reach full feeds by day 14 to 21 if there is no problem. A bigger baby, we try to reach within 7 days. Then Dr. Madhumita, hello sir, what about HFIV as a primary mode of ventilation in extreme preterm babies? It could be tried, because if you want to prevent the lung damage, HFIV can be used, but lot of people don't prefer, because most babies we are able to manage with just non-invasive CPAP or HFNC. So once routine thing is, most people are more experienced with conventional ventilation. Unless you are very, very experienced in HFOV, it should not be a primary mode of ventilation. But some of the units, even in Australia, like Melbourne, they use even HFOV as a primary mode when the baby is requiring assisted ventilation. But most of them don't use HFOV as a primary, but can be used. Then Dr. Junaid Mehraj, prophylactic surfactant was early rescue in very preterms, less than 1.5 kilo. As said earlier, there is no role for prophylactic surfactant. So you're not going to use prophylactic surfactant, because you will be using unnecessarily. Surfactant is given unnecessarily. You're invasive technique. Intubation is an invasive technique. Most babies may not require, because the early CPAP and effective support, most of these babies may not require a surfactant. So that is one reason. The other thing is prophylactic surfactant always you have to give in the delivery room or theater, where the condition is not ideal. You don't have all people who are trained. So the best time is get back to the NICU, you got all the trainers, do it totally aseptic techniques. So that would be the ideal, that too based on the requirement of the oxygen. So if there is oxygen requirement more than 30% or increasing oxygen requirement in extreme preterm babies where it's not coming down, you can go for early rescue. And in extremely, that is like 24, 23 weeks, in some of the units, they are using prophylactic surfactant, but it's not routinely recommended as of now. So there is an anonymous attendee. What about ROP and congenital thyroid screening? ROP screening generally in our unit, we do it only at 4 weeks of age, but recommendation as per NNF guidelines is you have to do at 2 weeks because most of the unit use liberal oxygen. First few years here, we were doing at 2 weeks, but then the ROP consultants who came, they said we are not seeing any problem in the first 4 weeks, so we can avoid in your unit because we have got a strict guidelines regarding the target saturation. So we don't see any aggressive ROP in our unit. So we don't do at 2 weeks, but we start at 4 weeks of gestationally. That is 4 weeks after birth, the first ROP screen, which is routinely done. Thyroid screening is done as early as possible whenever we invade and initially, and if it is normal, again, we repeat after 2 to 4 weeks. So these are the questions which I saw and I've answered. Any other questions? Akshay, Madhumita. Okay. I hope it was a useful discussion. Unfortunately, it's getting too late. I thought of discussing few aspects of different mechanical ventilation and also the inotropes, but it's getting too late. So we'll end the session here. Any other faculty online? Okay. Thank you. Thank you, Akshay.
Thank you, sir. Thank you, sir. Lavender. Everybody will be there.